said, what I'm going to be focused on today is the psychiatric and cognitive symptomatology that we're increasingly recognizing in individuals that have hydrocephalus as well as idiopathic intracranial hypertension. There's no disclosures that I expect to be relevant to the talk today. What we're going to go through is first some of the cognitive dysfunction that is sort of known or seen in individuals with these various conditions, go through the non-cognitive psychiatric symptoms, and the part that I consider to be the most interesting about what we're doing is going to be bringing it to the level of Hopkins, the work that we're doing with the Hydrocephalus and Cerebral Fluid Center, and really this exciting program that we're putting together to get these individuals comprehensive care. So what is IIH versus hydrocephalus? So they are two different conditions. Idiopathic intracranial hypertension happens when there is increased CSF, you have increased intracranial pressure, but you have normal ventricle size. And the etiology is largely unknown for what causes this. Things like being placed on birth control have historically been something that the medical students learn can drive something like this, and there does pretty clearly seem to be a link to menstrual cycles and sex hormones when it comes to this particular condition. And as you can see on the image that I put up here, you have normal ventricle size, and really the neuroimaging finding that you look for is papilledema. And historically, the thing that was most concerning in these cases is people would worry about them losing vision related to that increased pressure around the optic nerve. Hydrocephalus, on the other hand, is when increased CSF causes the ventricles to widen. And in these cases, intracranial pressure may or may not be increased. And there's typically an identifiable etiology. So that could be an outflow, obstruction, something disrupted with the absorption in the arachnoid, or excess production of CSF. So you're making too much, you're not absorbing it, and or it's not getting out in the way that it's supposed to. And what our work I'm pretty excited about is we're starting to try to understand, can these two conditions exist in the same person at the same time? From a definition standpoint, they kind of can't, because in IIH, your ventricles are supposed to be of normal size. But I think it would be short-sighted to not believe that if there's one condition where sex hormones can play a role, why could it not play a role in somebody that potentially was born with hydrocephalus? So a bit of a background on IIH. So first described in 1880, it has also gone by the name pseudotumor cerebri, benign intracranial hypertension. It's about 1 in 100,000 people, and you essentially have this evidence of increased intracranial pressure without a causal mechanism that's readily apparent. Symptoms tend to be, again, papilledema, transient visual disturbances, headache, tinnitus, nausea, really symptoms that you would think of when you think of somebody that has increased intracranial pressure. You will have normal CSF and neuroimaging findings, so that's where that lack of widened ventricles come into play, and no localizing neurologic signs, although you can have a sixth nerve palsy, which is the abducens nerve, so you get some difficulty with lateral gaze. And it's often a diagnosis of exclusion. I mean, largely, you're making sure, is there something else that's driving the increased intracranial pressure? Is there evidence of hydrocephalus, of some sort of obstruction? And then if not, this is a diagnosis that you would consider in the correct patient. So a bit of background on hydrocephalus, very broad topic. There are different forms of hydrocephalus. First described by Hippocrates in the 5th century BC. What he was really looking at was children with large heads, something relatively straightforward to identify, and in those children, they noticed that there was enlarged ventricles on autopsy. Right now, the rate is about 85 in 100,000. There's congenital and acquired subtypes. Because congenital hydrocephalus is often part of a genetic syndrome or spinal abnormality, you've actually seen some of those rates come down. For any of you that have children, you know there's testing that gets done when the woman is pregnant, and at times it can identify that there's something like a spinal abnormality, and then the family's giving a choice of whether to continue the pregnancy or not. Acquired or adult hydrocephalus comes in 4 major types: communicating, non-communicating, normal pressure hydrocephalus, and hydrocephalus ex vacuo. Communicating hydrocephalus, the fluid is actually able to get out of the intracranial vault, but the obstruction is somewhere outside of there, so fluid is flowing through the ventricles like it's supposed to, but the obstruction is further out in the periphery. Non-communicating, you have a blockage somewhere within the ventricular system itself. Normal pressure hydrocephalus tends to be in older individuals, or at least the symptoms present in older individuals. It probably develops over a number of years, and the pressure, as would be indicated by the name, is normal if you were to do a tap on that person. And then hydrocephalus ex vacuo is something I see a lot since I take care of patients with traumatic brain injury, so some sort of damage has happened to the brain. The brain tissue has shrunk, and now there's a space there, so CSF is going to fill up that space. Typically have normal pressure in those cases, although you don't necessarily need to. And a lot of times that becomes something static after the brain has done whatever healing it's going to do. And for hydrocephalus, that confirmation by neuroimaging is pretty key. So just a quick aside for NPH, historically discussed a lot more within psychiatry. It can mimic other psychiatric disorders, can help explain new onset psychiatric symptoms in an older individual. And there's a potential for significant improvement with treatment. So, on both campuses, there's clinics where you can go in, have some of your fluid drained, see if it results in improvement in symptoms, and in some of those patients, they will consider putting in something like a VP shunt. Hopkins triad is what we learn in medical school, so gait problems, cognitive impairment, urinary incontinence. That's the trio of symptoms that you often think about in these individuals. So now, I'm going to spend the rest of the time talking about our Scout-H project, and obviously named after Scout O'Donnell. We had to stretch a little bit to get psychiatry in there, but so supporting cognitive and psychiatric outcomes in hydrocephalus. It's a multi-phase project evaluating the presence and role of cognitive and other psychiatric symptoms in those with hydrocephalus or idiopathic intracranial hypertension. Some of the initial funding to do this work actually came from Scout's grandfather and to Jimmy and then to our group. And since then, Scout and her family have really stepped up and been continuing to work with us to figure out how can we continue to do the great work that we've started. So phase one, start like any good scientist would, examine what's known about the cognitive and other psychiatric comorbidity in these conditions. Phase two, take a look at that at the local Hopkins level within our clinic. And then phase three, develop a comprehensive screening and treatment pipeline for patients at Hopkins. The O'Donnell family, me, Dr. Luciano, feel strongly, just as Karen Swartz always tells us, don't screen for something if you're not going to offer a treatment. So as we're putting this together, if we're going to be doing screening, then we have to have a pathway to get anybody that's identified connected to treatment. So for that first phase, what we did is we undertook a series of systematic reviews of the literature to understand these two conditions, to take a look at what's happening at Hopkins locally, a retrospective review of EPIC data from the Hopkins Hydrocephalus and Cerebral Fluid Center. And in terms of developing this comprehensive pipeline, we're putting together screening protocols and accelerated referral pathways, and that's a collaboration between our department in psychiatry and neurosurgery. So let's look at what we've done in that first phase. So we started this work in idiopathic intracranial hypertension primarily because the research base is a lot more manageable. It's a condition that doesn't occur in as many people. If we would have started with the broad category of hydrocephalus, it's a pretty large undertaking. We wanted to get our processes together to be able to do this efficiently. So what I'm going to show you is our actual outcomes from IIH, and then show you where we're at working on something similar in hydrocephalus. So looking at cognitive symptoms in IIH, we ended up with a final cohort of 9 articles, 309 patients with IIH, 153 healthy controls. For anybody that's done systematic reviews, lots of variability in the literature, which is not uncommon. And what we were able to identify despite these limitations in methodology, deficits in processing speed, working memory, sustained and complex attention, set shifting, and confrontation naming. Those were the specific areas that continued to come out across the articles that we looked at. And BMI and body weight were not associated with these cognitive performance outcomes. So this was the initial work that we did, published in the Clinical Neuropsychologist. Great work done by our group. My research assistant at the time was Lisa Ritchie. She was the first author on this project. So now we have the same process ongoing in hydrocephalus. If you look at, just broadly speaking, what's known in the literature, congenital hydrocephalus, again, associated with genetic syndromes, when you look at the literature from like 60s, 70s, 80s, a lot of that is focused on the single dimension of IQ. It doesn't really dive too deeply into what are the different cognitive domains that may be influenced. More recent literature, that is certainly different, and that's what we're hoping we're going to be able to uncover as we do this work. We expect findings related to frontal lobe involvement, memory impairment, visuospatial impairments. There is more known about the cognitive changes in NPH. There can be short-term memory impairment, much like Alzheimer's disease, but with this added in extra executive dysfunctioning, impaired visual discrimination, and again, NPH, generally speaking, more well studied in that regard. So now looking at psychiatric symptoms, we're back to IIH now. So again, work that we've already completed. Final cohort of 8 articles, 724 patients with IIH, 257 healthy controls. Again, heterogeneous samples, variability in symptom assessment. But generally speaking, the literature suggests increased incidence of anxiety and depression, both the symptoms as well as the diagnosable syndromes, and increased headaches, visual disturbances, and overall poor quality of life in those that had a psychiatric comorbidity. One thing that I think Dr. Luciano and I are both interested in as we do this work is in these patients, when they are, for example, receiving a shunt, how does this comorbidity impact both the response to the shunt, but also how well they tolerate the surgery, what do their outcomes look like? And that's going to be some of the work that we'll be doing as we follow some of these people longitudinally. This was published in the Journal of the Academy of CL Psychiatry. This was work we did with a medical student. If those of you that remember Barry Naropreti, it was his student up at the Institute of Learning, so University of Connecticut student. And I'd just like to highlight that, how this work was able to be across institutions with various people being involved. Okay, and there was actually enough data available that we did a third review looking at sleep specifically. So this was a cohort of 6 articles, 316 patients with IIH, 84 healthy controls. Obstructive sleep apnea was more prevalent in patients with IIH, and that was independent of the BMI portion of it, although of course BMI influenced the rates. And it was associated with worse IIH symptoms, and treatment of OSA actually improved those symptoms. So again, showing the importance of identifying things that are treatable and then treating them. This one was published in Neurology Clinical Practice, and Sabrina Kentis is a medical student up in New York at Mount Sinai. So now, psychiatric symptoms in hydrocephalus. Again, these reviews are ongoing now. I think this portion of it's narrowed to 192 articles when I looked this morning, so still some work to be done. Congenital hydrocephalus historically has been associated with behavioral changes in school. That's kind of when you read the literature, the thing that pops up pretty readily, as well as depression and anxiety. And all types of acquired hydrocephalus are felt to have some similarity to what you see in NPH. So behavior change, irritability, depression, anxiety, psychosis. And it's also believed that hydrocephalus is also related to these sleep-related disorders like insomnia and OSA. And at some point, I'll be excited to give you guys an update on those 3 articles once we get them published. So now let's bring it to the local level at Hopkins. So this is work that we did with the help of Peter Zandi and Sazal. Really couldn't have done it without Peter stepping in and helping us to move it forward. took a look at available EPIC data. Special thanks to Philip Wong, who was a William Walker Award winner for this project. He's an MS2 student right now and really has been a person to help spearhead moving this work along. What we did is we extracted data for visits within the Hydrocephalus and Cerebral Fluid Center since the implementation of EPIC, so around 2013 in the outpatient setting. All patients 18 and above that were seen for at least an initial visit. We used ICD codes and the problem list for confirmed diagnosis of hydrocephalus or IIH. Presence of psychiatric diagnosis, again, using that problem list and ICD codes. And we also looked at, in those individuals, did they have an appointment within a psychiatry department or clinic here at Hopkins. So that got us 2,668 patients seen for IIH or hydrocephalus. And the rate turned out to be 31% had a psychiatric diagnosis listed on the problem list. We would imagine this is probably an underestimate, given that problem lists are what we make of them as providers. So you'd have to be relying on it being updated and accurate in order for it to pick up that comorbidity. No difference in age. The mean age was 59. You'll see some of that's being driven by the amount of NPH that's seen at that clinic. And no difference in gender. It was essentially 50-50. Those with a psychiatric diagnosis, slightly less likely to be married, slightly more likely to be widowed. This is a case where there's a p-value that might look significant, but the numbers are not all that different, but I wanted to present it to you guys. Less likely to be full-time employed, more likely to be disabled, and there was no difference in those with a psychiatric diagnosis based on BMI. So this is looking at the hydrocephalus types. So you can see the most common one in the clinic, the total sample is here in the, fifth column. And then this is those with a psychiatric diagnosis, those without. Normal pressure hydrocephalus, most common form seen in the clinic, followed by non-communicating, congenital, communicating, and post-traumatic, just a few people with that. And then that last row is showing you the number of people with IIH, again, smaller sample, which is what we expected. When you look at the sort of stats that were run on this, potentially a difference in communicating hydrocephalus, 7.2, there's potentially more individuals with a psychiatric diagnosis that had that communicating hydrocephalus. The rate is a little bit higher in that group. But generally speaking, you're seeing a decent number of people that are presenting with a psychiatric diagnosis across the various types of hydrocephalus that we looked at. So in terms of some of the psychiatric history portion, you can see both in those with and without a psychiatric diagnosis, pretty high rates of being prescribed a psychiatric medication at some point. Some of this is driven by things like SNRIs or other things that might be used to treat headache, amitriptyline. That's driving some of it, but not all of it. You also see when it comes to a psychiatric encounter, more likely in those with a psychiatric diagnosis. But this is where, retrospective review, you got to be careful. I mean, we have 83 people with a psychiatric encounter, but without a psychiatric diagnosis on their problem list. We don't yet know why, but it's a small enough sample that the IRB is looking at it to give us approval to dive into those charts individually to find out what exactly was going on in those folks. Those with a psychiatric diagnosis, slightly more likely to have a family history of a psychiatric disorder, and also more likely to have more diagnoses on the problem list. So is that more comorbidity? Or again, in those people where the diagnosis was listed, is it a more complete problem list that somebody entered into the medical record? This is looking at the different types of psychiatric comorbidity. I organized it just based on the percentages, and it's split out by male and female. The biggest differences in that regard, slightly more anxiety and depression in females and slightly more cognitive impairment in males when you look at the diagnoses that were in the medical record. Depression and other mood disorders was the most common. If you look at the total, about 15% of people, followed by anxiety disorders, and then followed by cognitive decline. some substance use disorders, and then things like bipolar, schizophrenia, delirium, those percentages get smaller and smaller as you go down. But really, depression, anxiety, cognitive changes are the kind of big three when we're thinking about where we might start when we're establishing something more comprehensive. And I just wanted to show that Phil ended up presenting this at his medical student symposium, and it was really well received, and we're really excited to keep working with him on this. So last part of this, what are we doing now? So we're actively developing a comprehensive screening and treatment pipeline for patients here at Hopkins. We have developed the screening protocol, and we're working on the accelerated referral pathways now. I just wanted to show the team. So Dr. Luciano and I are the two physicians on the team. Chris Cranston he's been a great colleague of mine. We did fellowship together here. He's within our medical psychology group. He's going to be the neuropsychologist doing this work with us and was involved in some of the initial work we've done already. Anna Dugan and Amy are two wonderful development officers. Anna and I work directly together. Phil Huang, who is our medical student doing the work, and then, of course, Scout Kemi and the entire O'Donnell family. This is a beautiful picture from her recent wedding. So Griffin and Scout, congratulations again. So let's talk a little bit about that pipeline to wrap things up. So the plan is starting with new patients seen by Dr. Luciano for hydrocephalus or IIH. Depending what those volumes look like, we may expand this out to other providers, but we really want to take on something manageable and do it right, and then scale it out from there. And this is going to be regardless of surgical plan, whether these patients are going to go on to have a shunt placed or not. For the identification plan, so this is a battery created by Dr. Cranston. We have funds to recruit a research assistant or a psychometrist to help with this work. I believe he's titled this, but someone from medical psychology, correct me if I'm wrong, the Hopkins Standard Minimal Assessment for Research Trials, or HSMART, is the battery that's being put together. And there's an in-person version and one that can be collected remotely. We would be doing the in-person version. That's what we would be shooting for. And the goal is to collect key measures of cognitive performance, depression, and anxiety. The symptoms that were most common are where we'd really like to start. And it's meant to have utility if the patient goes on to receive a more complete neuropsychological evaluation later on. This is the list of tests. It takes about, Dr. Cranston thinks about an hour to an hour and a half to complete, so it's not simple, it's not easy, it's meant to be comprehensive. Because of the type of symptoms that these individuals present with, we feel pretty strongly a MOCA or an MMSE may not be the right place to start to just collect that preliminary data if you're really trying to get a better sense of what does the symptomatology look like in this population, since generally speaking we don't know a ton about it. So you have stuff on here for visual spatial processing, various types of attention, learning, auditory memory, written memory. He's really put a lot on here. The one thing we still need to work through is whether the Beck depression and Beck anxiety inventories are going to be enough for the depression and anxiety component of this. The cognitive stuff, there's a lot, and we need to make sure that we're not missing out on those psychiatric symptoms, which is just as important to us as we're doing this work. So for those that are identified as needing additional neurocognitive or psychiatric evaluation, the plan is 0.1 FTE support for Dr. Cranston for those that need to go over and get cognitive testing done, 0.1 support for me to do the neuropsychiatric evaluation, and we anticipate still being able to bill for the services. This is really meant to hold time for quick availability. For those of you that see patients clinically, you know how difficult it is to squeeze them in. So if we're going to create something that actually has the potential to work from the beginning, you need that protected, supported time. Very possible once those clinics fill up, and if we know what the volumes are, that it just becomes a clinic that we work in. And if ongoing care is needed, then the research participant would be shifted to a patient of me and Dr. Cranston, or one or the other. And our anticipated rollout for this is the second half of academic year 25-26. Maybe we'll be able to roll something out a bit earlier than that, but I like to meet the expectation that I set out there, so we will have it up and running by then, hopefully sooner. So a few concluding remarks regarding cognitive and other psychiatric symptomatology. Hydrocephalus research has largely focused on IQ in those that have congenital hydrocephalus and NPH in those with acquired hydrocephalus. When looking at IIH specifically, the literature supports the presence of cognitive deficits, anxiety, depression, and obstructive sleep apnea in at least a subset of patients, with evidence that this can impact outcomes. SCOUT-H is an ongoing collaboration between psychiatry and neurosurgery, and it's going to start with patients seen in that cerebral fluid center, with initial estimates showing a burden of about 31% of patients and people that were seen there previously, with anxiety, depression, and cognitive struggles being the most common. And as I mentioned, a proactive pipeline from that clinic over to psychiatry is being established now. And I just wanted to thank you guys. This is a shot from Scout's Aspire campaign, which is still ongoing. She exceeded the first phase of support for the work. Then we're going to be doing some events in the upcoming months to further the work, with me and Dr. Luciano and Anna actually getting to go along and be part of some of the events. So thank you guys very much for your attention.
Thank you, Dr. Peters. Boy, that was extremely well done, and what a great thing to see you building this project. You know, I guess I think of one of the great things about Hopkins being that we have people who develop very, very deep expertise in a niche, and my sense is this is probably a niche where there are not a lot of people who've. You're breaking new ground, I think. And
yeah,
becoming
Jimmy,
an expert.
I looked back through my email. You had messaged me about the O'Donnell family years ago, and I took a look at that time. Very little was in the literature. We got an appointment scheduled, and it's really all gone from that time. I think you and your wife had run into the family, and that's how it all started. And Dr. Luciano, interestingly, Dr. Luciano and I haven't had a chance to meet in person, but we've been on plenty of calls together. That also shows the way life is these days. So I'm excited that we're going to be at an event together relatively soon. But without that partner and colleague, we wouldn't be able to do any of this. So that's going to be a really important part of it.
Fantastic. Well, I have lots more questions, but I'll see if other people. Yeah, go ahead. Go ahead.
Thank you, Dr. Luciano.
Thank you.
Nice to meet you in person.
Thank you. Folks have
He's busy. He's busy.
question. Go ahead.
Hey, Idris. What a great question. That's the hope. Yeah, I mean, that's absolutely part of what we're hoping. Now, there are some people that already go and get cognitive assessments around the time of having shunts placed. There is some of that already happens in the population that's seen. We're trying to do it in a much larger number, but yeah, I absolutely think something pre and post shunting and adjustment would be quite interesting, and that would be part of the plan. Thanks, Idris.
Great, thanks. Another question back. I saw someone else had their hand up. Yeah, go ahead.
My name is Lisa. I'm a nurse practitioner at Children's Mental Health Center, which is an outpatient child psychiatry. And I'm just wondering about, I remember our best symptoms started in the pediatric years and maybe. So I'm wondering if there's thoughts about expanding this to include pediatrics, or if maybe there's something in the way.
Yeah, that's a great question. Nothing on my end specifically. That doesn't mean we can't and shouldn't do it. I mean, Mark, are there folks that do this in kids that you think would be interested?
Yes.
Yeah. So we'd have to put a team together. I think it's absolutely worth doing. We would need to build out a team to do it. Right now, again, the feasibility part of this is really important to us, so we're going to start in that adult population, but there's no reason why we couldn't develop and build a model that could be used within the children's centers as well.
Dr. Paula.
Just wanted to know if there are treatments other than shunting, and in particular, I'm calling patients with proliferative gambling and who had sensitivity to high medication, and which is basically cured by the former single diagnostic, but symptoms go away. I don't know if that's a common or a very uncommon.
It is known that one of the breaks the cycle is a cycle which is great to lower the pressure than could have lasted. That is not very good. But there's other treatments. Obviously, the effects of time on medication.
Right.
Interesting.
Separately, right.
Thanks. Dr. Bray.
I was really sort of struck by your kind of symptoms I was feeling, what you were experiencing. It strikes me that there is a great deal of diversity in the symptoms that these folks experience as a result of the same problem of overtraining and undertraining. What do you know about what sort of differences account for that?
What a Michael Bray question. Man, I don't think we have an answer. It's a perfect question because and Kemi was just telling me about another family member they have that also has hydrocephalus and is incredibly sensitive to pressure changes. I mean, maybe Dr. Luciano knows, but I don't know the reasoning for why some people are more sensitive to it. But I think we feel strongly that is the case, that there are some people that are more sensitive to it. The siphon guard that Dr. Luciano put in, it changed your life. I mean, it was exactly what was needed because she's so sensitive to those changes, and this helped to prevent that. So you'd imagine if there was another patient having a similar experience, at least we know something we could potentially suggest to them. But I don't know how we could have predicted this difficulty in Scout versus somebody else. It's a great question, Michael. Maybe that'll be part of what we start uncovering.
Let me you want to ask a question?
Would logic dictate that Dr. Vaccaro's success as a surgeon, or Dr. Luciano, I'm sorry, his success as a surgeon in, for example, doing a shunt that the primary determinant of success or his outcome would be the psychological change?
I think we both feel strongly that that's a big part of it. I mean, if somebody's not doing well from a mental health standpoint, now that could also mean that they have an idiopathic standalone mental health condition that we need to treat, or could mean that these symptoms are being driven by the hydrocephalus itself. But that's, absolutely true in a lot of chronic conditions that you, from a mental health standpoint, you want to optimize somebody for them to have the best outcomes. Yeah.
Let me, you know, go ahead. You had another point. Thank you. Thank you. I want to ask one last question, Dr. Peters, which is to get to the point that I think I understood Scout making when we were talking, and that is there any role for some larger kind of screening for people who might be exhibiting personality changes or psychiatric symptoms, and it's not immediately obvious, but you might wonder whether there were...
I think the answer is almost certainly yes. I mean, a lot of the cases that I take care of are those cases that there's just something extra going on, headaches, pressure, and you just wonder what else might this person be going through. I think with a lot of the autoimmune encephalitis cases, those sometimes go years before it's identified, and some of the identification only happens because of a seizure or because it got bad enough. But yeah, whether it's hydrocephalus or one of the other neuroinflammatory disorders, I think we miss it quite often.
What would the main indications be for putting someone, sending someone for screening? Would a headache be?
Yeah, I mean,
key
headache.
thing,
Typically, we'll see subtle neurologic exam findings in the cases that we take care of that don't necessarily map onto a single part of the nervous system, but it just like looks or feels different. And I mean, in my practice, we get a lot of neuroimaging, so we don't miss that often. And I think a lot of the residents are trained to get neuroimaging when there's a question about, you know, do we actually know what diagnosis this person has? But if it doesn't feel typical, I think as you gain your experience, you start identifying people that there's just something extra going on, and you got to figure out what it is. But it happens quite often in the cases I take care of.
Okay.
Yeah.
Well, thanks so much for a great grand rounds. Thanks to Scout. Thanks to the O'Donnell family. Thanks to Dr. Luciano.